My name is Seth Martin. I'm with the Center for Health Technology and Innovation at the American Heart Association. I'd like to welcome you all here to our health tech competition. It's going to be a competition with a twist. So you've probably seen a famous TV show where people pitch a little bit, and they get some top hard questions from an investor, and then they beg for support. We're doing it a little bit differently here. We're going to pitch on business today. We're going to pitch on science and impact tomorrow. We're going to have expert judges both days. Some will have some new judges. I don't have time to introduce our judges one by one because they're all so esteemed it would take 2 hours just to do that. So look at the slide when it's up and memorize their names. I'm going to hand this off now to Dr. Peterson of our Health Tech Advisory Group, and he's going to bring us in.
Thank you, and it's a great honor and privilege to be here. I'm Eric Peterson from UT Southwestern and a long-time Center for Health Technology and Innovation volunteer for the Heart Association. We've been running this competition for years. It's running a little bit different as we mentioned this year. We're going to have some smart people initially evaluate the business job, and then we'll be back tomorrow to look at the science perspective and their impact on patients. This is competition, just so you know, is like one of the highlights of the Heart Association meetings, so hope you enjoy very much. We'll rank them, they're just slightly above the puppies over there. But don't go yet. Don't go yet. These are great opportunities to see this all. I won't keep any more of your time. We'll get on to the competition.
Thanks so much. All right, so we're ready? Again, people, audience participation, energy. A lot of these companies found out last week that they had to be here today. Out of their pockets, they're paying to come here because we are a nonprofit. So they had to get here on their own. So I want to see some enthusiasm as they pitch. Anyone freezes? Start clapping. No one will, because they're all really practiced. So we'll call our first contestants. Laura's from AvoMD.
Mic check. All right. Hi, I'm Lawrence. I'm the co-founder of AvoMD, and AvoMD is bridging the gap between guidelines and care. As a disclosure, we're a member of the CACI network, and as one of the co-founders, I used to be a private equity software investor. I come from a family of physicians, and I ended up getting my MBA at Columbia to combine software with healthcare and medicine. At Columbia, I met my two physician and informatics co-founders, board certified in both internal medicine and informatics. Yair, our CEO, previously founded two nonprofits, and our CTO is a part-time doc at Harvard, and he's a researcher in AI and UI and UX. So the three of us came together at Columbia to solve the problem that both PJ and Yair were facing as practicing doctors, which was they were frequently overwhelmed by the amount of information they were expected to know, deploy, and use for the patients they were seeing at the point of care. On top of that, the solutions they were given were not adequate. The clinical guidelines and hospital pathways and binders were unwieldy and unusable at the point of care. The BPAs, or best practice alerts, they were getting in the EHR, if anything, exacerbated the problem. And then the applications available in their EHR were very non-scalable and unique to every single disease state. And so what we have done is we've built a solution that takes the clinical knowledge, so that could be clinical guidelines, hospital pathways, AI predictions, really any type of clinical knowledge, and that gets transformed into point-of-care decision support without needing coding experience. So we built an application to help clinicians build their own clinical decision support applications without needing IT or coding knowledge. And our point-of-care application is available in Epic, in the EHR, or outside of the EHR, really when and where the clinician might need that guidance and decision support. So here's how it works. This is a hypertension module we created with the AHA. Let's say a patient's coming in for an initial evaluation. They're in a certain BP category. We can pull in their comorbidities with an EHR integration. And based on their race, because treatment is different based on race, you get an immediate guidance on how to treat this patient for blood hypertension. And any one of these green links you can click into and get embedded information, decision support. You get very quick guidance on what to consider for comorbidities, for example. You have references, links to the underlying studies, really making the guidelines come to life and be usable and accessible at the point of care. And any of this can be customized for the hospitals that use the builder. So the providers are the ones who are consuming our knowledge. They can build and supply their own and sell that to other providers. We're partnering with the societies themselves, though, and these societies are the knowledge suppliers. And we're taking their guidelines and actually making them available for free on our platform with funding by life sciences companies. So we're vested interest in getting the evidence with their products in it into the workflow and at the point of care in an unbiased, trusted way because it's coming from the societies. We deliver value across these different segments that we work with. So on the provider side, we've done multiple RCTs and QIs and studies that show our software improves outcomes, saves clinicians up to 50% of their time at the point of care, and reduce costs for the hospitals that implement us. For societies, we're driving impact for their guideline work. We're giving them a new revenue stream by sharing revenue when we monetize their guidelines from life sciences. And for pharma and device companies, we're driving point-of-care awareness of other products in an evidence-based, unbiased, and trusted way. We're also giving them new digital access to providers as well as data. We have been fortunate enough to partner with leading health systems and providers across the country, including Extension, Columbia, the VA, Geisinger. We're doing a lot of work in cardiology, which is why we're here. So the AHA, Society for CT, are some of our big partners, as well as about 6 others. And on the life sciences side, we've been fortunate enough to work with Roche, AstraZeneca, Medtronic, Siemens, and Provino. So what's next for us? We're currently wrapping up our fundraise. We just signed a term sheet with the lead investor. It's been a fun ride in this market. I'll just keep it at that. We're approaching $1 million in recurring revenue, so that'll be a big milestone for us. Working on deeper EHR integrations like ordering from EHR and adding more guidelines onto the platform. And our asks for today are, if you're a provider or you're a life sciences organization, come talk if you think there's synergies with us, and feel free to check out our free app. Thank you.
Any hands I have for me? So here's how the question period will work. The judges have 4 minutes to ask questions. Some judges, sound bites, tiny questions, little tiny questions. I'm going to keep you on track. I'm going to keep you on track. So let's get started. Who's got a question?
Question. Since today's focus on business commercial viability, what is your acquisition cost for new providers? And then number 2 is, what is your actual cost? What is your monetization? Monetization model and cost.
So the way we're going to market is actually a lot of our society partners introduce us to pharma sponsors of their guidelines, because we're giving rev share to societies when we monetize their guidelines. We get a ton of introductions to decision makers within the commercial org of pharma, and so those are kind of free intros in a way, but we're giving rev share when we monetize, and rev share is generally between 10 and 20% of the monetization. But that allows our customer acquisition costs to be essentially very minimal up front, because we're getting these high-level direct intros as we're aligning incentives across all the stakeholders.
Competition and then the challenge of integration with the various health systems who have a long list of things that they're working on.
So on the competition side, there are kind of 2 flavors of competition. One are the kind of reference tools of the world, so like everyone knows UpToDate, founding CFO of UpToDate just joined our advisory board as a little aside. But those tools cover everything, but they're really not designed for point-of-care usage. They're not really software tools. And also, like an UpToDate or any one of these publishers, they don't provide institution-specific knowledge. So formulators are different depending on where you go, and every hospital treats manages guidelines differently. So that's one flavor of competition. The other are solutions that are essentially sending alerts in the EHR which we all know are interruptive and alert fatigue is real, and that's kind of what we're up against and solving for.
Good job. Curious, 2 questions. What's your TAM, and what are your first customers? So total attributed market, and who are your first customers?
Our TAM, if you want to do bottoms-up analysis, you could take, there's about 4,000 clinical guidelines in the world. Right now, we're pricing each guideline anywhere between 100 to 400K in annual recurring revenue. So if you were to say, 4,000 times 400,000 is our kind of max TAM. And our first customers have been, on the provider side, folks who have their own local protocols and are really solving for some acute quality problem and are using our tools to help ensure standardization. And on the pharma side, it's folks that have drugs or products embedded within the guidelines for the first time ever, because that's a big deal, and they want to get those guidelines into the workflow and as available as possible.
We have time for one more.
Can you give us some color on the user experience and like NPS scores or anything like that from the physician users of your product?
Sure, yeah, so we generally get NPS scores upwards of 70. If you saw from the demo, we're very much focused on giving clinicians quick access to the info they need and helping them in their workflow. So we like to look at the average session time on the platform. That's under 30 seconds. And we actually don't necessarily want clinicians spending too much time using our tools. And then we've done like a usability study that showed our software rated like a 94 on the system usability scale. And we've proven it saves clinicians up to 55% of their time relative to using up-to-date and other status quo tools.
That's great. I think we'll have to wrap it up there. Thank you very much, AvoMD. So judges will have just a moment to tabulate their insights, their scores, holding their future in their hands. And in the meantime, get ready to introduce and welcome up Lunar-Tech. Come on, applause.
Thank you. Can you hear me? Yes. Hi, I'm Asif, founder and COO at Lunar-Tech, and I'm going to tell you how we are building precision care and data services with female physiology at its core. Okay, here are our disclosures. Clearly unable to work this remote. Okay, so you already may be aware that the problem women globally face with the standards of care for cardiovascular disease and stroke is the lack of longitudinal and real-world data. Meaning that when we design targeted drugs, treatments, and diagnostics, they only sometimes work for women as well as they do their male counterparts. This comes at a huge economic and social cost that can be significantly reduced if we intentionally design for the female physiology. The AHA has made it a priority to study women, and we want to help. We give you Lily, our patented platform that is collecting medical-grade longitudinal data and generating real-world biomarkers without changing a woman's lifestyle. At the heart is our patented augmented garment that collects medical-grade data, including a multi-lead ECG, temperature, impedance, and activity. Lily is connected via Bluetooth to a mobile app where we continue to collect electronic patient-reported outcomes, and then the aggregated data is transferred to a secure server. Our technology has a huge impact on our patients, because just by having a woman naturally wear the greatly increase the amount of longitudinal real-world data. By seamlessly integrating to a variety of bras across size, shape, and style, we are able to increase the representation of all women in data for research and drug and treatment development. Building on 30 years of evidence of sex differences, and then building the robustness of our data sets, we will be able to decrease the disparities in health and reduce the economic and social burden. We are already doing this today. Following success in our early feasibility studies at the MIT Computational Cardiovascular Research Group, we have been able to close a seed round to increase our production capacity. And we have launched a campaign for women to wear it for women. Today, we have built a sustainable revenue model with our commercial and research partners, starting with a multi-year MSA with a pharmaceutical, where we help them expand drug indications for existing drugs and provide evidence on cardiac safety for emerging drugs. With increasing inbound interest from commercial partners, we are on the journey north of 10K, where we will be deploying 10,000 devices with commercial partners to increase decentralized studies and more unique data sets we can build across patient populations. This is the amazing team working on this. So if you're interested in addressing health disparities using Lilly, let's talk. Thank you.
Outstanding. Under time, which is always appreciated. Questions from our panel?
Yeah, thanks. I was wondering why limiting this technology to women. Seems to me that it can really establish the rules as well.
I love that question. Thank you. So again, I think today, because our data research is predominantly from males, we're even going to specify that males from a certain kind of background, race, weight, age, that most devices are already built for that population. Anyone not represented in that data falls to the mercy of the adverse outcomes that we deal with. And especially now, as more healthcare companies introduce AI that are dependent on the quality of that data, we will continue to see the increase of adverse reactions.
But just to follow up, in terms of your business position, you stand to gain a lot by expanding your potential
100%.
population.
And I think just as women have benefited from so much research on men, men will benefit from a lot of research on women.
Some quick questions, please. There are a number of wearable devices that are collecting data. So this form factor for use, battery life, length of time it's usable, is compared to patches or other devices that could be used. And then Makowka can also compare some devices to those.
Thank you for that question. And so there's a growing trend that these technologies are trying to go smaller and smaller and to help with cost. But I think when you see women in STEM designing for this solution, we actually looked at the torso and what we can do around the heart and lungs. And we actually can take advantage of a lot more real estate to increase the processing power and that fidelity of the data for improved diagnostic yield. So that's exactly right.
Quick question. Right now and just follow up. So battery life, how long can it be worn?
So right now we're aiming for the standard of care, which if those patches are prescribed, they're around 24 hours all the way to 2 weeks to 30 days, and that's what we do. That's the battery life.
Do you have to remove the product, the patches, or you just wash the garments, and what's the longevity after that?
These related to mine?
Last time.
Go for it, go for it.
So we actually have the device at our table if you want a live demo. We're still showing my live heart rate because people think I'm too nervous. But so studies, we've standardized the bra that we use as a supporting garment. This attaches to any bra and is as washable as the bra that a woman uses. So she throws it in the washing machine, it's clean, and she uses it again. The idea is that we are able to use, again, multiple locations for an ECG around her torso to acquire a lot of data points that are usually less reliable from a single week.
Very quick. Very quick.
So, follow up on your question, do you have to take the device out of the garment to wash?
It's part of the garment. It is washable as is.
And then how long does it take to recharge?
So, again, across the standard of care, so if it's prescribed for 2 weeks, we charge it once.
Okay. And, sorry, one last question. Main distribution of the product is?
So currently we work with commercial partners. The first one is a partner, but the research channels have right now been inbound interest through our network. So you can see a lot of the partners we work with are physicians, and we've been partnering with their organization.
Thank you very much. We'll reset the clock. We'll give the judges a moment to tabulate. And this is a great time as a reminder, after the competition, don't rush over there right now, but all the finalists are exhibiting right over here at these round top tables. So you have the opportunity to follow up with them if you have more questions, learn more about their amazing technologies. Judges, are we in a good spot? Heads are still down, see pens still moving. All right, let's get going. All right, I'd like to welcome to the stage, Cipherome. Applause.
Hi, we're Cipherome. My name is Seth Ali. And the last speaker, Asif Ali, in fact, set up this conversation because we're bringing the power of genomics and AI to be able to minimize adverse events. So we're talking about a process that starts in drug development. My colleagues and I are with us today in the room. We are a member of the Health Technology Innovation Congress. Now make it to this slide. And there are some other things that we work on at Cipherome because we believe in inclusion and in participation of all people. I have no other conflicts of interest. And to motivate the problem.
Put the mic close to your mouth. Nice.
To motivate the problem, let's talk about what we find typically today. There's about a $100 billion problem on adverse events that happen in the U.S. alone. So these are categorized typically as hospital visits to the ER or surgeries and the like. So these are not allergic reactions. This is not having to do with low-level issues. And in particular, this starts when new drugs are targeted because generally drug companies maximize signal and minimize noise. And so they try to get that homogeneity of patients, despite the fact that many organizations like this are trying to be inclusive in clinical studies. We have 6 clinical studies going on, and we strive for diversity, so we have to go overseas. We went to South Texas, where our market access study has 95% Latino patients. I'm not going to report that today, but that study measured twice the prevalence of polypharmac genes in that patient population than had been observed before, and these patients present at a much later stage of cardiovascular disease than what typical patients present at Mayo, Cleveland, and Mass General. So in terms of getting to these patients, it's super important because there are 2 phenotypes that come. One is an example that was published by Alan Wu from UC San Francisco that you see on top, which was the dad of one of the students who passed away after 2-stent procedure and at 3 months had an MI as he was in the soccer field and expired on the way to the hospital, and he was resistant to antibiotics. So the drug he was on didn't have the full benefit he would have had. And the second is an example which is very typical of Asian patients where indeed it's probably not likely statin neuropathy, but once leg cramps develop, people stop all the medication altogether. We hear this continually when we're out in the field, and the question is it ancestry, is it genetic factors, medications, etc.? In our specific case, we have 3 product lines that are at different stages. We moved from clinical to commercial stage this year on the Lighthouse platform. We developed a genomic platform, and that is, by the way, just primarily a genomic platform, and you see a sample report on the left that's being used at 6 clinical health networks. There's a platform to do genomic and clinical factor research. And then what our main goal is, and what we've raised over $20 million against, is to be able to combine genomic and clinical factors at point of care to be able to find the phenotypes that are buried in the data that we all see today in cardiovascular research, but that doctors can identify and treat. In fact, my 2 prior speakers, I feel the 3 of us should be doing work together. The other example is, I'm going to say this is not, right, this is not, there's an extra chart here, I didn't realize. So this is an example of visualizing the solution. We do this automatically. Think of an expert chart review. We already today, with UK Biobank data, routinely use for our own research and optimization of algorithms that combine genomic and clinical factors. We can look at patient longitudinal information. So not just diseases that they presented with, but the interventions and medications, so that we can factor in known pathways and known targets into the treatment. This is a large market. We started with the clinical channel. As I shared, there are 6 health networks. We started with DHR Health in South Texas, about 1 million patients, and about 3,000 patients through the cath lab a year. There are 2 health networks here in Chicago that are going to start using our platform to be able to help patients identify metabolically impaired patients, so that they have a rationale to keep them on Brilinta versus Plavix. And in this size of market today, it's about a $2 billion market according to Medicare reimbursement. There we go. We have also partnered with lung severance and soul, again for cardiomyopathies, looking at genomic and clinical factors, and we're selecting 2 different people, and we have 6, we believe this market though is $30 billion, and it's at least as large as the oncology marketplace because of the number of AFib patients. And then lastly, just to share where we are in the market space, this is a very large market in health and AI. That $100 billion market, there's a $30 billion genomic biomarker, which is the AI machine learning place. We hope to capture a couple % of that in the next few years, but our real goal is to be able to bring this into point of care. There we are. This is our team there.
Give it fair. Let's hear it for Cipherome. I've been saying it wrong the whole time. Wonderful job, judges. Questions?
Question. You mentioned that this is a large market, but there's also many players in this market. The pharmacogenomics and biology clinical practice for many years. But my worry was that the patients were receiving very large EOBs. The costs were prohibitive. There was lack of interoperability. It was difficult to onboard information and get the platforms to get that information back to the EMR. Are you addressing the cost factor? How much does it cost with pharmacogenomics now to the patients receiving EOBs, and how are you interoperable in that process?
So I think there are 2 questions in there. One is affordability, and the second is integration of clinical workflow. So over the last few years, there have been 2 major clinical studies in cardiology that reported in 2 meta-studies. So as of the end of last year, Medicare in every single region in the U.S. reimburses pharmacogenomic tests and has established medical necessity for both ACS and CAD. So from a perspective of reimbursement, our reference lab is qualified with CMS and we're not getting any pushback. They reimburse nationally at $288 a test. Private insurers, including the AIM contractor for Blue Cross Blue Shield, now also reimburse without prior authorization. So it's been a tectonic shift because the FDA have recognized CPIC, which is an NIH-funded society that curates what these guidelines are. And from, I think your second question, with respect to interoperability for us, if you manage what you measure, so if the result isn't back into the clinical workflow, it's hard. And we've seen 2 adoptions. So with DHR Health, our tests are ordered through their EMR. They created a simple EMR integration. They haven't yet created alerts against it because not every doctor is ordering the test. This is really a physician-based, but we have a simple fire integration back. I showed you a report, it's very simple, just discrete data, but that in fact has been, 10 years ago, These were $2,000 to $3,000 tests in 2 months turnaround time, now it's a few $100s and it's a week turnaround time.
I was happy to ask Neil's question because I was looking at his notes. And so tell us a little bit more about the business model, because you did explain it's a test, it's ordered, it comes back to your lab, you're doing analysis, you're pushing results back to the EHR, and then what? And so tell us a little bit more about how it works. Thank you, Neil.
So the business model, there are reimbursement codes for these tests. As I shared before, genomics accounts for about a third of the variability of patient response, not 100%. And even today, we understand that thromboses that happen post-stenting, really only about a third of those related to stent. 2/3 are after thrombosis. So you're really dealing with the patient's long-term effect, right? And so in the specific case, it's very small, but the recommendation back is not genomics. It's basically to avoid, in this case, clopidogrel for those patients. For psychiatric patients, it's a more complex menu of what SSRI, for example, to treat depression and generalized anxiety disorder. But so from the business model, it's test reimbursement, right? But we think this is a partial solution ahead of being able to combine genomic factors. And just this year alone, a team out of Mayo, University of Florida, published the first study using clinical factors and genomic studies. We were able to minimize both ischemic risk and bleeding risk in post-stented patients. And for us, that was a Hail Mary that somebody else is looking at. Please.
Very fast. Well said. So congrats. The way you set up your value prop is that your solution can potentially tackle issues on health disparities, but the use cases that you are utilizing, such as large academic centers, are typically going to address it. So how small clinics and the like, would they be able to do that?
So thank you so much. I feel if this thing were to work a little better, you would see here, those are not large health networks. There are over a dozen large academic health centers, some of whom are on this panel before and early in the morning, that have implemented their own version of this. Here in Chicago, North Shore, as possibly one of the best application installations. These groups get together twice a year and we share what our clinics doing so you get a sense of the implementation. We're trying to bring it to everybody else. We're bringing those same guidelines to everybody else. And in particular, we started in places that have people of color, because as I shared before, they're the most at risk. Thank you so much.
Wonderful job. A round of applause, please. 5 minutes back up on the clock. Judges, how are we doing? Taking notes? Ready to proceed? Okay. I'd like to call Nimble Heart. Applause.
I'm Sonal Tambe, co-founder and CEO of Nimble Heart. I would like to thank the AHA team for giving me this opportunity to talk about Nimble Heart, where we are taking preventive cardiac monitoring to the next level. My co-founding partner, Dr. Deshmukh, and I, we decided to found Nimble Heart because traditionally, exercise ECG monitoring has only been used for preventive care of cardiac rehabilitation patients. As such, we all know through AHA data that cardiac rehabilitation patients who are eligible versus those who attend and adhere to the cardiac rehab is around 20% as a national average, which has been still affected during COVID. Cardiac rehabilitation is a secondary type of preventive care. There are other cardiac risk populations that also need primary prevention. For example, the first responders, the men and women in uniform that save others' lives, they themselves are at risk of cardiac deaths even on duty. The athletes who push themselves the best for their performance are inherently having cardiac risks. And we believe the world is ready at this time to go to a level where exercise ECG monitoring is available to all the cardiac risk individuals, just like your dental checkups. And the problem at this time is there is no technology, there has been no technology available to allow administration I'm proud to announce Nimble Heart Physiotherapy Smart as our FDA-cleared solution to this. Nimble Heart Physiotherapy Smart is indicated for exercise ECG monitoring in all the outpatient settings such as home, office, gym, and alternate care settings. And when we build a medical device, it is not just some wearable ECG. It has all the clinical features. For example, the placement of electrodes, the material of the electrodes so that it doesn't cause rash on the patients, the compatibility with implanted devices, the ability to work with obese patients, and most importantly, the ability to clean and reuse in a very safe way in hospital scenario. Our device can be cleaned with water, wiped clean with water and alcohol, and it is safe, found safe by the FDA for all patient use. And of course, the heart rate alerts that have to come in seconds as per the FDA guidelines. Our value proposition, first of all, our patented dry electrode technology works so easily that it can be worn without any skin preparation. Secondly, it has been designed to work well with women and men anatomy, and its form factor allows it for women to wear it conveniently with their regular outfits. In fact, I have a monitor on me at this time, and you will see my live ECG on the iPad right after the presentation. Our value proposition, we would like to support the increase and adherence to cardiac rehab enrollment through virtual rehab telemetry. And going beyond that, we would like to offer an affordable and routine exercise ECG monitoring to all the at-risk population where they can get proactive diagnostics, treatment, procedures, and optimize the healthcare costs. Our marketing early adopter customers have been the customers who have structured preventive care and wellness programs. And that's why we started with cardiac rehabilitation, both the hospital as well as independent rehab providers. Like we have a company moving analytics here, for example. We also have customer in first responder wellness programs. And we have started an early engagement with some professional athlete physicians as well as athlete trainers, where we offer routine exercise ECG monitoring on site periodically during their tryouts. Our business models are very flexible. We offer purchase as well as lease models. Our lease models work very well with cardiac rehab programs because they can be tied easily with the monthly reimbursements. So in this journey that started with NASA spaceflight monitoring contract all the way to the commercialization was accomplished with a very experienced team. Sitting there is our ECG designer, including cardiac, clinical cardiology, sensor design, and most importantly, our industrial and material design was done by no one but the sports bra expert of America, who have the data on where men and women sweat, how their muscles work, and where the electrodes should be placed to get the best signal during exercise. So at this time, as a startup, we have conquered all the risks, such as technology risks, regulatory risk, and market feasibility risk. And at this time, we are ready to take the next lead through marketing and growth to take the next steps in terms of making preventive cardiac monitoring go big for all the at-risk population. Thank you.
That's perfect. Thanks so much. Good job, everybody. How everybody felt it? Good for you. All right, judges, do we have any questions?
I have a question. Talking about dry electrode technology patent, yet Zoll, LifeS, HM, and Cardio, who also came out with a device that also doesn't require any gels or interface. How are you different from, how is your patent different from those technologies that also use dry electrical physiology?
So yeah, our pattern, and frankly, I did not have an idea of what we will end up doing when we started Nimble Heart. Our pattern is mainly about motion artifacts, and dry electrodes are not just by themselves, but whenever even you breathe or or if you move a little bit, the electrical impedance can get affected and your signal can become noisy. So our first patent about this is motion artifact mitigation in wearable, and our second patent, which is in provisional state at this time, is about getting ECG signal noise mitigation when the patient is sweating profusely.
So you mentioned kind of three somewhat distinct but obviously related markets. How are you thinking about focusing amongst those, and are you sequencing and prioritizing them in some way that allows you to kind of penetrate one and expand from there?
Good question. And cardiac rehab is a market we have got a little bit handle on. We know it well, and we have established channels. So mainly it is a B2B market, but we are selling through selling like a consumer product or something. So it is through the channels and through our partnerships. So we have, instead of having a lot of small customers, we have multiple big customers. For example, when we have a contract with a big hospital chain, we don't have any other sales or marketing efforts, but only account management efforts when they expand their program to their multiple centers for cardiac rehab. And for both the first two markets, our product and business models are identical. It's only the third market where we have not started yet in that market. It's early stage, and we'll need funds and we'll need more team members to address that market.
Congratulations. Can you get a sense of how well this works with different body pathogens?
Yes, and I will talk about that more in tomorrow's slide deck for science evidence. But yes, like I said, in the clinical study, and FDA specifically asked us to do a clinical study on this part of my language, but men with different hairiness on their chest and different bust sizes for women. And the clinical study had to give safety and performance requirements for the FDA before the product was approved. And sure enough, it does work on men and women of all the types in the field.
No question?
Really quick, in terms of the product, is there a clinical team at your company that monitors the data, or you're relying on other companies that buy the product and use it to do that monitoring?
Yeah, good question. So exercise ECG normally needs to be monitored by someone. So our first two customers have cardiac rehabilitation as well as the wellness customers. They have staff that use the device and they are watching people either live or virtually. And with our third model, we will be offering that service. So it will be a completely different type of model.
Wonderful. That's great. Do you want to go on to Nimble Heart? So, judges tabulate. No time for side conversations, Lee. I'm kidding. Go ahead.
We're getting our questions prepared for this.
Wonderful. Well, proactive judge. So just as a reminder, we are doing this again tomorrow, but the focus will be on the science and impact of each of these solutions. So come on back, hear that part of the pitch, because it's not all about money, except when it's all about money, and then it'll be about impact as well. I also wanted to admit, we have one more contestant up. Opsis, they're last because we went in alphabetical order. There was no preference here. Appreciate y'all staying around this late. After the pitches are over with, we'll take these results, they'll be put in a login file with the Ernst & Young, and then tomorrow we'll tabulate the full scores to come up with both category and overall winners. And also say hi to our finalists after the show. Get their high top tables over the corner. So I'll give it away to us.
Thank you, Jeff. I'm Jim Barnes. I'm one of the CEOs and COO at Opsis Health. We're here to, our mission is to revolutionize the health of people on the planet. Small objective, right? So we have nothing to declare here. We have assiduously rejected any kind of investment from anybody that doesn't care to follow the science of health and nutrition and diet quality. All our investment has come from wealthy, mission-aligned investors, no institutional investors, and no conflicts of any kind. So what's the problem we're addressing? And there is nobody in this entire conference here that doesn't have somebody that has chronic conditions. So if you look back in 1985 in the map in the upper left, there was no state that had more than 15% of their population that had a BMI over 30. What's a BMI over 30? If you're a 5'4" woman, that means you're 30 pounds overweight or more. So nobody had more than 15%. By 2020, there's 16 states that are approaching 35% BMI. If you look at the JAMA projections, by 2030, we're going to have 50% of the population is going to have BMI that's over 30. So if you look at the lower left there, what we're doing today is not working. Calorie counting doesn't work. Calories in, calories out does not work. There's been thousands of diets. There's tens of millions of gym memberships. There's thousands of devices from the Thigh Master to the Peloton, etc. None of those work. There's been Fen-Phen, Olestra, and now we have all the GLP-1s like semaglutides, right? Can you lose weight on those? Yes. Are you healthy when you do that? If you still have poor diet quality, yes. You'll still be unhealthy and you're only treating the symptoms. On the lower right, obesity and a high BMI is only a symptom of a poor diet quality. It's part of the metabolic syndrome now. All those conditions there, many of which fit right into the cardiovascular area, are actually caused by poor diet quality over a period of decades in that. We're addressing that. So what are we doing about it? Specifically, we introduced a new tool, you can come back and we'll demonstrate it live for you, that uses machine learning, AI. We have big data technology in there, 52 million data points merging 9 international databases together. And then we use advanced behavior science. We will reduce from you doing a 4-second scan of your food and drink at each meal. We'll take that and we'll deconstruct it all the way down through portion technology that we have, to canonical recipes, to every ingredient by measuring it in there. We sum up all those nutrients and we come up with a single number called your DQV, or your diet quality value. That single number is the most important number in your world. It's more important than your Social Security, savings, etc. That number, if you keep that number at 80 or above, you will prevent most of those chronic conditions, dozens of chronic conditions. You will maintain a healthy weight. All of those will be accomplished by following that. And if you look at the rings below that, if you want to know how to get a high DQV, just touch that ring and we'll tell you exactly what foods you need to eat and how much of them for that meal and for that day on a continuous basis. So there's 5 innovations here that are important. The first one I just talked about, DQV. The second one is, you touch any of those rings, we'll show you all the examples of foods and how much you have to eat to have a high DQV. We'll track it over time. One meal, 1 day's worth of food does not make a good or bad diet. It's only what you do over time. So just like your A1C, we're tracking your DQV over time with a 4-second scan. We also give you a tool to walk into your grocery store and scan any of the packaged food items in there, and it will actually show you immediately what the nutritional value is of that food, looking at 54 different variables, including minerals, vitamins, processing, phytonutrients, etc. So you can pick good foods. Notice the little green circle will actually tell you what the sustainability of that food is for the environment. If that number is above 40, if that number is above 50, the food you're eating is sustainable. It can continue that way. If it's below that, you should probably not eat it. And then the EQV on the right is actually a score on 0 to 100, the same, but it's your environmental metric for that. So, what's the value proposition? Well, if you're a citizen, it's preventing, mitigating, and reversing chronic conditions that you saw. You'll achieve a healthy weight by not going on a diet. If you use any diet in the world, you still need to use this tool to know whether you're getting a quality diet and all the nutrients in the right amount that you have for each meal. If you're a care provider, you can evaluate in 10 seconds with the dashboard we have whether your patients are eating a good diet. That diet itself is going to determine it. So you can walk in there and you can say, if your DQV is 70 or 80 or above, you don't need to worry about their diet. If it's less, you do. You can chase off. So, what's the TAM? Everyone in the world needs. Right? This is an absolutely free application for you, and who's going to pay for it if it's free for you? Anybody that wants to help you with your health and monitor and give you recommendations, they will be the ones that pay us. 137 million people were on a diet this year. 133 million U.S. citizens actually have multiple chronic conditions. And so, raised $14.5 billion for Jeff. And we've done that all through private, no institutional investors, and we'll raise another round, but it's unlimited scalability. We're starting to ratchet it out this month. We'll start, if you go back and scan our QR code at our desk, you'll be put on the list. People in November will start getting it. We're expecting it to be very viable by the tests we've done, and we expect hundreds of millions of people to be using this and use that data for research.
Outstanding. Images. Oh, it's already got it in his hand. Okay.
is exciting.
So I know this space pretty well. There's a couple of competitors, Small Plate, Food Street Health, where you can take pictures of your food, send it to a nutritionist, up to the medicine. The patients who have enrolled in those trials, having them stay on and actually taking the pictures is a limitation. Number two, sometimes they don't take pictures of everything. They'll take pictures of the good food, they won't take pictures of the candy that they're taking. I'm more interested in the application where you're actually scanning the food and getting the calories. How accurate is that? Because once patients don't get that accuracy, they stop using that tech. So I'm just curious on the accuracy of scanning, like the sandwich, and how it can delineate the different weights as well as content of that.
So it's actually a long conversation where we build our own scientific devices that take thousands of 4K images. We've had hundreds of people for many months actually scanning food. We actually have the only ones that have portion technology built in there. We have lots of patents around that. So when you do the scan, the reason we do this instead of an image is we take 120 images, we attach the AvoMD data from the phone to that, we reconstruct the three-dimensional model of it. You'll see some more on that in the science section tomorrow. Then we take that and we connect it to a canonical recipe, and that canonical recipe has all the ingredients by measure to it. And then we take that and we add up all of those ingredients from everything that's on that plate and everything you've done for the day to calculate that DQV. Go back and scan our QR code that was on the screen for a second. We have all the scientific papers on how we do the calculation and how the technology works, and we'll talk some more about the science tomorrow.
Thanks. Could you just go over your monetization model again? I think you said it was free.
The application is free for you to use to get healthy, and I don't mean freemium. We don't mean that you're going to get a few features and you have to pay for others. Your data is private. We don't spam you. There's no ads, nothing. Everybody, like your clinician, if they want to see your nutrition manifest that we generate, and come back there and we'll show you a picture of what that dashboard looks like, if they want to monitor you, they'll pay us $10 per month. If your fitness coach wants to help you lose weight and get into shape, they're going to pay us $10 per month. If your weight management or if your corporate wellness wants to keep their healthcare costs down and they want to know what your DQV is to determine that, they will pay us $10 per patient or client per month. So you never pay anything, but the people that are going to make money off of you one way or another will actually pay us in order to see that data. You could walk in there and just show it to them if you want. It's completely free.
Yeah, I was just wondering, how did you take into account worldwide variation culture of food as well as you?
So we actually have international databases that we have now. The initial application that's rolling out now, although it will go out internationally if you're on the list and you've done the QR code and that. And it is in English today, but for the databases and that, we will slowly go to each of the countries in the world over the next 2 years, and we will incorporate everything from coaching in language-specific ethnic cuisines and all the things that are adjacent there. So it does incorporate all of the typical foods that all the recipes around the world create. Will never be 100%, which is why when you do the scan, if we don't have it in our database, all you need to do is touch the food and put a name on it, and from then on, it will learn it for you, and we'll add it to the database, and it goes into the training models for the inferencing and that the machine learning does. So it's going to be like Google Maps when it first came out, right? It doesn't necessarily have all the speed limits and all the things around you and know when there's accidents, but it was really good, and it got you from point A to B. That's exactly where we are with Opsis.
Real fast.
Real quick, I understand your targeting users, everybody, but do you have a sense of initially to get started, who the early adopters are, kind of characteristics of who you think is going to be the first to build that community around your product?
We have lots of events internally, but we think it's from 25 to 55 that care about health and weight. Those are the two primary. But the sustainability piece of that, if you talk to teenagers that are still invincible with their diets, but they care about the environment and the planet, we'll show them exactly what the effects is of the foods they're eating on the sustainability of those foods. So we have a bet, is it going to be that middle section, or is it going to be the teens? And then of course for chronic conditions, but that won't be the first thing that gets adopted. And we've done our virality studies, and we think it's going to be in that 25 to 55 category.
Sorry. I'm afraid I'm going to have to cut off there. Applause. Thank you. So this rarely happens at a conference, but we're running a little bit ahead of schedule. So we thought we'd take the time and give you the time for the judges just to say a couple words and introduce yourself, and then we'll wrap up. Jim, we'll start with you, Seth.
Everybody, Seth Martin, a cardiologist at Johns Hopkins in Baltimore. I have a number of hats I wear with the AHA. One of those is the center director for our Health Tech and Innovation Centers. We call it MTech, and
Hello everyone, I'm Anekwe Onwuani. I'm a heart failure cardiologist and also the president of the Association of Black Cardiologists.
Good afternoon, everyone. I'm Azizi Seixas, associate professor at the University of Miami and former director of the Leading Innovation.
Hi, I'm Shapiro, managing partner of Seth Ventures, and apparently doing a poor imitation of Eric Peterson, whose picture is up on the slide.
I'm Neil Patel. I'm one of the logos on the left. I'm the head of the Ventures at Redesign Health.
Good afternoon, Heather Provino. I'm a health tech founder and entrepreneur and CEO, now helping digital health companies grow.
I am Asif Ali from the University of Texas Health Science Center in Houston, and I also am a CMO of a number of health tech companies.
Let's give a round of applause for our judges. Give a round of applause for yourselves. Should be the biggest one. Thank you so much for your attention and attending. We'll see you here again tomorrow at 11:30 for the exciting conclusion of the Health Tech competition.
Thank you.